Hello, and welcome to the Osteogenesis Imperfecta Foundation's podcast series. My name is Danielle Simber, and I'm the Communications Manager at the OI Foundation. On each podcast episode, the OI Foundation brings you information about the diagnosis and treatment of osteogenesis imperfecta, presented by an expert in the field of OI and rare bone disease. The podcasts are a part of the ongoing educational effort of the Brittle Bone Disorders Consortium, part of the National Institutes of Health Rare Disease Clinical Research Network. Our podcast today will focus on measuring efficacy of physical rehabilitation in children and adults. We're very excited to have with us today Dr. Maureen Donohoe, outpatient physical therapy clinical specialist at Nemours Alfred I. DuPont Hospital for Children. Dr. Donohoe will be presenting the information that she's presenting at the OIF scientific meeting this weekend. Thank you so much for joining us today.
Hi, so I'm going to talk about measuring efficacy of physical rehab in children and adults, and what I'd like to think of it as what we did, what we're doing, and what we should be doing. So the objectives for this are the participants should have tools to quantify participation to assist individuals in becoming more active. They should recognize differences in testing based on environment, educationally based, multidisciplinary clinic-based, episodic care, post-fracture and/or surgery. They should understand limitations in some of the standardized testing tools for the OI population, work on consensus on what is important to track over time, and participants who function in a multidisciplinary clinic should have tools that track skills over time. There's many reasons for measurement, and some of the few reasons include justifying or quantifying for services, or justifying or qualifying for services, track change, track effectiveness of medical treatment, compare individuals within similar populations, and to compare individuals against general populations. So let's take a quick peek at the Icf Classification. The Icf is the International Classification of Function, and it looks at a health condition, and it breaks it down into body functions and structure, activity and participation, and then it considers contextual factors such as environmental factors and personal factors. So let's talk about this in terms of osteogenesis imperfecta. If you're looking at body structures, you're thinking skeletal structure, range of motion, muscle strength, posture, pain, and fatigue. If you're looking at activity, you're thinking transfers, bed mobility, gross and fine motor skills, and self-care. And what we're really looking for is the holy grail, which is participation, and it involves activities involving others, vocational activities, avocational activities, and management of the home as an independent individual. The contextual factors that we're looking at include things like age, education, desires to do things, psychological issues, and financial aspects. Some other of the contextual factors include logistics, the ability to do the thing based on what they own, accessibility, can you get out of your house, can you get to an activity, and the support that you need in order to do that. So let's look at osteogenesis imperfecta in terms of testing tools when we're looking at the Icf classification. So if we're looking at tests for body functions and structure, we're looking at skeletal imagery, we're looking at goniometry, manual muscle testing, postural assessment, pain scores, fatigue scores. Tests for activities can be broken down into single task activities where you're just doing one task and measuring it, or multiple task activities, and we'll talk about that at greater length. And then there's tests for participation, and many of those are self-report tools that we look at to see how participation goes in life. And things that impact from a contextual factor is the age. There's no test that goes from birth to old age that covers the lifespan that you can take with the individual. And then there's the contextual aspect of financial aspects. Who's paying for the testing and the therapy? Because some places you get therapy easily, and some places you don't. And then there's the logistics. How do we get the community serving the OI population to do the same thing? So we're giving care that is similar no matter where you live. The accessibility, how do we get the OI community to the right providers to get them what they need? And the support, how do we support the therapists in the community to test what needs to be tested and give the patient information to build a personal database? So where do we measure? There's several places that therapy is measuring. One is in a research protocol. Another is an educational environment or an acute care as an inpatient stay, or a rehab model, inpatient and outpatient, and a multidisciplinary clinic. Each environment has very different time constraints, needs, and goals for measurement, and you have to be sensitive to that. Places like research protocols, the tools need to be sensitive change for the specific population. Some of the tools that we see in this include the brief assessment of motor function, or the BAMF, which sets a baseline of skills so you can figure out where you're going to start with your testing. The gross motor functional measure, the GMFM, it tracks change across an individual. Unfortunately, both of these tests are really designed for those that are under 18, as is the PD or the PD-CAT, which is an assessment of activities of daily living, or the OI-QOL, which is an OI-specific quality of life scale. There's also the PODCI and the PROMIS, which are self-assessments. The only test that I have mentioned in the research protocol aspect is the PROMIS that will go across the lifespan. And that starts at 5 years of age. So in an educational environment, many kids will get PT and OT services, sometimes speech services, and they'll get it from birth to 3, and then 3 to 5, and then school age. So you have early intervention, preschool, and school age, and there's testing that is done in order to qualify, and you often will use multiple task tests, such as the Bailey, which goes up to 3 years, the Peabody Developmental Motor Scales, or which will go up to 6 years. The Brunick-Ostrowski Test of Motor Proficiency, or the BOT, goes 4 years to 21 years. And then there's the School Function Assessment, which goes kindergarten to 6th grade. All of these tests have their positives and their negatives when it comes to qualifying for services, because when you're looking at some of the tests, some of the skills that you would expect a individual who had bone fragility, you wouldn't want to put them at risk of harming themselves in the testing situation. So you need to be careful about hopping skills and balance beam skills and some of the ball skills. And so you can't get a pure score as kids get older if you want to be conservative. In that model, I like the school function assessment because it looks at mobility within a school environment. It looks at transfers within the school and within the bathroom and the school bus. It also looks at playground skills, which I think that when you're looking at a young individual, being able to do those skills with the least amount of support is nice, and to be able to track that over time is great. But these are all multiple task tests. Multiple task tests have benefits of qualifying for service. They give normed reference data, and they track changes over time. The drawbacks is sometimes they qualify kids for service before we're really ready for them to qualify for service. Sometimes we don't want our babies to have an aggressive therapist coming in and pushing skills before they're developmentally ready, because we want to protect their spines and have their head control and their trunk control ready for sitting and standing before we start facilitating that. Some of the test skills may not be appropriate for a child with OI. and they age out of the test relatively fast. So they may not own the skills, but they may be too old to take the test, or they may not have enough skills to take the test to score effectively. And for those that are wheelchair users, none of these tests, other than the school function assessment, really look at function from a wheelchair level. And many of our individuals do function from a wheelchair level the majority of the time in the school environment. So looking at an educational environment in single task tests may be helpful because we want to be able to track change, we want to track improvement, and we want skills that will be beneficial for functional skills, such as being able to get from your chair to the whiteboard to be able to write on the board, or you want to be able to stand to be able to manage your clothing, or you want to be able to get out on a fire drill safely. Or you want to be able to sit on the floor with your friends and then get up and be able to get to the next activity. So some of the single task tests, I'm a big proponent of timed tests. So time standing balance. Can you stand statically? Can you stand on one foot? Those timed skills reflect function and change. Gait speed. If you have a distance that you have to be able to walk every single day, how fast can you do it? And can you improve that? If you're a wheelchair user and you have a manual wheelchair, can you consider a 10-meter shuttle ride where you're pushing your wheelchair 10 meters and see if you can get faster at that? One of the gold standards for endurance is the 6-minute walk test, which I think is wonderful in a school environment because you can have a child work on walking as far as they can go in 6 minutes. In a medical environment, often if you do that, you can't do anything else afterwards. But in a school environment, if you make them walk 6 minutes, then they need to rest, you've used your therapy time. But it's a good test and it will show change. Also, the 2-minute walk test is a smaller version of the 6-minute walk test. And it makes it so 2 minutes would get you from the classroom to the library or to the bathroom, and it would help you speed up things. The timed up and go is an interesting test for someone who functions in a school environment who's ambulatory, but you have to, in order for it to work well, you have to have the chair height measured consistently. So if you're going to test them in a chair that they can reach the floor with their feet, you have to measure that a future time to get a reproducible data. And then the timed floor to stand, where you sit on the floor, you stand up, you walk 5 meters, and you come back and sit down. It is also a nice tool for changing speed. And I think that would be a nice way to help write IEP goals. So the educational environment, the testing will qualify for appropriate service. They encourage safety, self-advocacy, and independence in the school environment. And a lot of times the PT and the OT come along and they are the advocate for the student. But they also are the ones that have to teach the student to be their own advocate. And one of the things that I find to be really important is school needs to teach children to be adults that have lifelong fitness opportunities. School therapists see individuals on a weekly basis, and they have an individualized educational plan for them with goals. And they're responsible for tracking those goals, and they're responsible for giving the families a report card that tells them how they're doing on their goals. So if we're doing timed tasks, it gives the family a nice report card of how things are going, and it gives them a record over time of how things are changing in a positive or a negative direction and help them define strategies. So the educational environment can be very important when it comes to tracking physical and occupational therapy goals. Now let's move to a new environment. Let's talk about acute care. It's inevitable that our OI families end up spending some time in the hospital, either because of surgery or because of fracture. And typically therapy comes in and their goal is to get them quickly and safely out the door while educating the caregivers in the process. So we need to have them get as many skills as possible to get them home safely. So in all reality, we're doing a lot of education and not a lot of mobility other than bed mobility, transfers, and in and out of bed, as well as bathroom transfers when appropriate. But we can measure those. We can measure those by how long does it take to roll over, or how long does it take to scoot in and out of bed, or how long does it take to get onto the toilet from the wheelchair. Because sometimes that in itself is so time consuming and you feel a little bewildered that it's taking so long, but you can look at it and say, oh, we're making gains. We've gotten faster. If you get to a point that you've been in acute care and you're not at a point that you can get out of the hospital quickly, a lot of times an option for inpatient rehab will occur. And it's a transition from inpatient acute care to a facility where you can work on functional skills so you can have your caregiver be able to help you at home and have it safe and somewhat independent. But you have to go through intensive daily therapy in order to gain these skills. So a lot of times if you're put into inpatient rehab, you're in rehab and doing therapy 2 to 4 hours a day. And you have to be an active participant. And sometimes that's a little daunting. But what are the things that we're going to measure when we go to rehab? If you're a child and you're anywhere from 6 months to 7 years, a lot of times rehab facilities will use a tool called the Functional Independence Measure for Children, also known as the WIFM. If you're an adult, they'll use the functional independence measure called the FIM. And both of those tests look at multiple skills and give you a score within the first 72 hours that you're in rehab and then when you're discharged. It really doesn't look at anything other than you came in the door and you could do this and you left and you could do that. But it's a nice thing to do. And then there's the physical assistance scale that will look at how much assistance you needed to be able to participate in the first day of therapy and how much assistance did you need at the end. And that scale, they usually will plan for how much improvement you'll have as they're writing goals. Sometimes we'll look at the children's assessment of participation and enjoyment, as well as the preference for activities of children, which is the CAPE and the PAC. And that's for ages 6 to 21, just to make sure that we are looking at what they're interested in and getting them to where they can participate in what they're interested in. There's the timed up and go. For those that are ambulatory, there's the sit and reach and the stand and reach. The challenge for the sit and reach and the stand and reach, they're both tools that look at balance and fall risk, but sometimes you have bowing and limitations in raising arms that make it that you can't get a reproducible number on a regular basis. But what we're looking for is excursion. There is no normed reference data that matches these sit and reach and stand and reach activities for the OI population. It's just graded against norms. And my guess is, I have no data to support this, but my guess is that the population as a whole would come out with a bit of a bias towards fall risk because of their limitations of their extremities, as well as their spine. Another test that we'll use in inpatient rehab is the PD, or the PD-CAT. It is a tool that is a self-assessment tool, and it looks at activities of daily living and the amount of assistance that you have. The PD itself is a very lengthy document. The child should max out on that somewhere around 6 years of age. The PD-CAT is a computerized version that gives you not as many questions. It's somewhat predictive, and it ages out closer to 15 years of age. So it gives you a longer duration of use, and it's sensitive to change over time. Once you've achieved your inpatient goals, which would be to be able to go home safely with a caregiver assistance, or if you're an adult with less assistance if needed, you will move to outpatient rehab. Now, sometimes therapy is done in an outpatient clinic that is not associated with the hospital, but it could be a freestanding orthopedic clinic. And intensity is often based by need, and it can be an episode of care around a post-operative condition, a post-fracture rehab, or just a tune-up to get more skills. And it's not to be considered an individual's recreational activity, but it's considered to be very goal-based. So an individual needs to come in the door with, I want to achieve. Measuring goals in the outpatient environment, you need to be able to have things that will travel over time. So we're going to look at something like a 6-minute walk or a 2-minute walk. My bias in the outpatient clinic is a 2-minute walk because I want to do more than just walk in my session. If you have an individual that lives in a home that has stairs and they are ambulatory and they can do stairs, then I timed up and down the stairs is a nice test to do. If they're functioning from a wheelchair level, I want to do time transfers and figure out what the priority is for that. A standing person, I'd like to do stand on one foot if possible, because that would translate into being able to lift a foot to go up a step, or be able to step over the edge of a shower stall, or to be able to lift a foot in order to get a pant leg on or something like that. So I think that standing on one foot is somewhat important and is a good timed measure. The GMFM, again, is a measure that can be used to looks at change across the person themselves. But again, this is a measure that was designed for the cerebral palsy population. It has been used with OI, but it's not referenced as predictive for the OI population. There's leisure checklists. There's other tools that can be used to figure out participation within environments and performance measurements that could be used. And often those are things that are questionnaires to figure out where you're going. And really, when an individual goes into an outpatient environment, they come in with specific goals, and they really should have those goals addressed specifically. So if they want to get better at transfers, you're going to test transfers. If they want to get better and get more endurance to be able to get from their car to their work and be able to do it without assistance, then you want to work on that endurance. The episode of care in an outpatient model really should be goal-driven for the individual. Now, when I work in a multidisciplinary clinic, and in that clinic, we collect data on an annual basis. We want to make sure that we're meeting the individual's needs. Now, for that environment, we are seeing individuals, it's PT, sometimes OT, it's orthopedic surgery, it's genetics. Sometimes we have the brace people come in. Sometimes we have the rehab engineer come in. It tends to be a very busy clinic appointment. And in that, the therapists have 30 to 45 minutes to address everything that's going on. So we need to figure out what their problems are, track their change, educate them, address equipment needs, and bridge to the community therapist in 30 to 45 minutes once or twice a year. So Testing tools need to be quick, they need to be easy to administer, and not completely fatigue out the patient. But they need to be able to track change over the lifespan. Because in my mind, when I have a 5-year-old that comes into me, I think of them as the child that's going to age out of our system, and I want them to have the package to be able to go into adulthood and be able to be a self-advocate. So I really emphasize evaluation tools that look at activity and participation, because that's what I want them to have. We have done everything possible in the way of testing. So we have used every testing tool out there, starting from range of motion and manual muscle testing to the POTSI, to the PROMIS. We've done P-bodies, we've done GMFMs, PDs. We've done everything we can, and now we're working on teasing out what we need and what will travel across the lifespan. So about 3 years ago, I started using the PROMIS, and I started using it because they wanted me to use the POTSI. And the POTSI is a really nice tool because it looks at a bunch of different dimensions, but it doesn't go past age 18. It starts at 5 and it doesn't go past age 18. And the PROMIS is a tool in the NIH toolbox that the short form is free. It's easy to score, and there's adult versions of the forms. So I chose 5 dimensions to look at, and I look at pain interference, fatigue, physical function, mobility, physical function, upper extremity, and peer relationships. And with those 5 dimensions, there's 8 questions on each one. So then that way I can have a set of questions that I'm asking, and it will cue me how much is going on and what's interfering. So at least I have something to start when I'm looking at where do we have to have our talking points and where do we need to be going. And the nice thing is there's adult versions to match the pediatric versions. And when kids can't fill out the forms, there's parent report forms also. So in our clinic, what we're doing right now is we give everyone a self-report tool. So the PEDS-QL is an infant tool that we give for birth to 2 years old. And then we give out the PROMIS for parent report until the child can fill it out themselves. And the child can usually fill out their own PROMIS somewhere around 8 years of age. And, I trust what the kids tell me. And we are moving towards giving out adult forms for the older teens, because when I talk about peer relationships and social interactions, some of the things say I can play with my friends, and I've had quite a few teenagers say, well, I don't really play at this point, so it's not really an appropriate tool. So we're looking at changing it up a little bit, but we give out the PROMIS. We do baseline goniometry and strength assessment as it impacts on alignment and function, because a lot of times when kids are coming in, I'm seeing a child with the orthopedic surgeon, and we're thinking not only what's PT doing, but what are we going to be doing orthopedically to make them more functional or have better alignment or address some pain issues. So we look at goniometry and strength together. I use a tool called the Observational Gait Score for the ambulatory population, and it's perfect. It isn't deemed the OI population necessarily, but it gives me a number score that I can track change, and it looks at how their foot hits the ground and what their knee is doing and how they are, what their base of support looks like and what assistive device they're looking at and how much better or worse they're doing since the last time I saw them. For the children under 3, I typically will use the P-body because we're not hopping and jumping yet with the under 3-year-old population. Once we get to hop and jump, I get a little nervous unless they're those kids that are doing that already. I'm not hot to push it. We do a quick review of equipment needs, and we review the needs based on their local services. So a lot of times people will come to clinic and we'll take measurements and we'll talk to them about what they're doing and what their local therapist concerns are, and then we'll try to bridge the gap between the two. So what should we be doing in clinic? We should be collecting data that grows with the individual. We should continue with patient-reported outcomes such as the PROMIS and the PD-CAT. We should be doing timed tasks. We should be doing reaching tasks and measuring distance of reach, because it's not only about can we judge fall risk, but can you reach a cabinet from your wheelchair? And can you get your clothing out of your closet? And how can we figure out how to get a better reach? We should be looking at an endurance measure, and we should be looking at 2 minutes versus 6 minute walk, or some sort of wheelchair mobility speed to be looking at endurance. One of the challenges on a caveat for the mobility issue, if you're a wheelchair user, is I would say that 75% of our kids do not come in their personal wheelchair the day that they come to therapy or clinic. So it's kind of hard to test them appropriately if you're not using your appropriate wheelchair when it comes to wheelchair mobility. And then another thing that we should be collecting is what is their personal technology that they're using, and how can we use that to impact on feedback for the individual. And the personal technology is, what is that cell phone, or are they using some sort of Fitbit or Apple Watch that would give them feedback so we could have them collect data for us. So then that way, not only are we collecting data, but they're collecting data and they're keeping track. I'm a huge fan of the Apple Watch these days because it has a wheelchair basis also, and it has activity circles, and they can figure out calorie count and activity movement and reminders to move. And I think it's really important to give all of the collected data back to the individual so they can help us keep track of what's going on. What else are we doing? We're measuring everything we can. We're starting to settle into our measuring expectations. The Canadians have been really good at measuring, and they've been doing measurement for probably 15 years or more consistently. And here we are in the US, and we're just like in the infancy stage of making sure that we're doing it on a regular basis and having an expectation for it. And we need to really be settling into things that work for this population. And we need to be collecting data that is comparable to the general population. So then we're not just looking at OI, but we're looking at how the individual with OI functions within the bell curve of the typical population, so we can advocate for more services if necessary. And we need to see a relationship between those who have no ability to manage self-care and excess body weight. Because in my clinic, I'm finding that we are seeing so many individuals that are overweight, and being overweight is very disabling, but when I do a self-report measure, I'm finding that they're not doing any self-care skills. So self-care becomes exercise. And if we find out that they're not doing anything and begin exercise as a self-care expectation, we're burning calories. What should we also be doing? We should be building consensus on important measures for the OI population. So providers are collecting similar information. If you're in a multidisciplinary clinic in Delaware, or if you're in the middle of nowhere in New Mexico, you should all be collecting similar data. So then that way we can say to the individual with OI, you had this data set, let's use your information. And we need to identify measures that will carry the person through adulthood. We need to use tools that reflect change and fluctuation and function. And the stopwatch for me is a really nice way of showing change, because speed is indicative of change. And you have fracture, and prior to this fracture I could do this task in 25 seconds, and now it takes me 3 minutes, but you know that you did that before, so you can get back there. If you educate the local therapist to address the problems and not get hung up on the diagnosis. I can't tell you how many times somebody comes in the door and says, I can't find anybody in my local area that does OI. That's true. But you do have people in the local area that do musculoskeletal pain and strength issues. And you can go to somebody and they can address your problems, not your diagnosis. So we need to share the data with the individuals who have OI so they can create a personal file to help track their change. So when they go to the individual that doesn't have any experience with OI, they can say, well, I used to be able to do this, and this is where I want to go. As they age out of the pediatric world, they should learn how to advocate for similar functional measure use in the adult environment so they can track their personal change. For individuals who are doing no aspect of self-care, use of self-care as exercise until they are able to do the skill independently is exercise. And once they have that skill of self-dressing or even toothbrushing, once they have that skill, then you can add a new skill on top of that, and that becomes exercise. And we should be encouraging activity for lifelong fitness. Thank you.
That was great information. Thank you so much for joining us today, Dr. Donohoe. Listeners, if you have any questions or comments, please contact the OI Foundation at bonelink@oif.org. You can find all recorded OIF podcast episodes at www.oif.org/OIF podcast. Thank you for listening, and stay tuned for the next episode.